Thanks to everybody who's joining and viewing this video. I'm Karthik Murugiah. I'm an interventional cardiologist and assistant professor of medicine at the Yale University in Connecticut, USA. And I'm also the executive associate editor for JACC. And it's my absolute pleasure and honor to invite Dr. Jasmine Marquard, who's from the Department of Cardiology at Riggs Hospital at Copenhagen in Denmark. And she's here with us to tell us about her study that's going to be presented at EuroPCR in a few days. That's titled 10-Year Outcomes of Complete versus Infarct Artery Only Revascularization in STEMI in patients with multivessel disease. And this is a 10-year analysis of the DANAMI 3 PRIMULTI trial. This is obviously an extremely popular topic to study for interventional cardiology research groups the world over. We had the portion of several trials in this space, starting from, the early ones in TREMI and CVL PRIT trial, followed by the larger complete trial, and then we had the Compare Acute and the DANAMI 3 PRIMULTI, which was FFR-based trials, and then there's been another really large trial from Sweden, which is a full revasc trial. So. Again, we've had the fortune of several of these trials, but this will be the first time that outcomes are reported in a 10-year time horizon. And this is obviously a class 1 recommendation at this time in the ACC/AHA guidelines for complete revasc, but there's a lot to learn about these long-term horizons. So Jasmine, welcome again, and thank you so much for taking time out. And tell us the motivation behind the study. Is this something that you had intended to do or sort of pre-specified? And what were the things that you were planning to look at this 10-year time horizon?
Thank you so much for the introduction and the presentation. So DANAMI 3 PRIMULTI was one of the first trials to actually investigate complete revasc compared to culprit only in patients with STEMI and multivessel disease, as you said. And the primary trial had a follow-up of about 3.4 years. And we now wanted to do an extended follow-up to look at the long-term potential benefits of complete revasc in these patients. And we wanted to do this as none of the other trials had the long-term follow-up. The longest follow-up we have is 5 years at this point. So it's really unknown what potential benefits complete revasc will lead to on the long term, if any. So we looked at the DANAMI 3 PRIMULTI trial, and the initial follow-up was, of course, we had an event committee that adjudicated all the events. And now for this extended follow-up, we had 2 independent reviewers that assessed all hospital records to adjudicate every single event occurring in the extended follow-up period. And the primary outcome in this extended follow-up was the same as the original trial. So that was all-cause mortality, myocardial infarction, and revascularization. And then we also looked at the independent components of the primary outcome as well. Moreover, it was we thought it was very important when you have a 10-year follow-up period to actually also look at repeated events, as patients could undergo multiple revascularizations and suffer from more than just one myocardial infarction during this extended follow-up period. And seen from a patient perspective, we believe that it was crucial to not only look at the first event, but also the events occurring afterwards. So the primary findings of the study was that the primary endpoint, which was all-cause mortality, myocardial infarction, and revascularization, when treated with complete revasc, we saw an association of a relative reduction of 25% in the complete revasc group compared to the infarct-related artery only. And this was the same as in the main trial, and it was mainly driven by revascularizations. So we didn't see any significant association between complete revasc and death or MI alone, but complete revasc that reduced the occurrence of revascularizations. Also, we assessed certain subgroups and we found a significant interaction between complete revascularization and age, so lower age, and 3-vessel disease regarding the primary outcome. And then in terms of the repeated events, we saw that there was an absolute reduction of 30% in patients treated with complete revascularization compared to infarct-related artery only. This was, however, a non-significant association or reduction with confidence intervals crossing unity.
Yeah, that's really interesting. Obviously the question here is also with complete revasc. One would hope maybe you would reduce AMI, etc. down the road, which we don't really see in this trial, but we've seen in other full revasc trials. So do you think it is something to do with the size of the trial? For example, in complete, you have much larger trial, and they were able to show some reduction in hard endpoints. And what do you think may be potentially a role of FFR? And what do you think? Is that a right lens to view complete revasc? Because we've had a lot of divergent data in that. For example, in flower AMI, we saw that there was really no difference between these two strategies of using angiography versus FFR versus frame AMI, in which we saw very different results. So what are your thoughts on those?
Of course, it's relevant to talk about that we didn't find any association between mortality and AMI and complete revasc, especially when considering the complete trial. And I think you're right in terms of the main issue here may be a question of power, or maybe power. The DANAMI 3 PRIMULTI trial only consisted of 600 patients as compared to 4,000 patients in the complete trial. So the main issue may be power. However, it's of course impossible for me to say exactly what may be driving this. But another possible topic that needs to be discussed as well is, of course, the FFR strategy. As FFR detects ischemia, and with these patients, an FFR negative lesion can still be a high risk plaque with the eminent plaque rupture and subsequent MI. And these patients were not stented in the PRIMULTI trial as they had an FFR negative
and my understanding
value.
is about 30% of maybe lesions were not stented due to that, which again has varied between the trials, and that also throws a bit of inconsistency in the mix of the results. Because in some trials we've had really a lot of lesions deferred versus in others there have been less.
Exactly.
Yes.
When you compare that to the angio guidance, the angio guidance may lead to stenting of these high-risk negative plaques, and then preventing the future events. And this could be this could be what we see in the complete trial. Also, it's worth mentioning that we have the PREVENT trial in stable patients that investigated high-risk plaques and negative FFR negative lesions, and found that preventive PCI reduced the risk of MACE compared to no preventive PCI. And maybe we could not only translate this into this cohort as well, but it may be actually even more pronounced in patients with ACS, as we know they are more prone to having these high-risk negative plaques.
Right. And I remember reading something from Prospect about more layered sort of plaque phenotypes in STEMI as opposed to even other forms of ACS. And given that DANAMI, is a STEMI trial, so that is also something that is important. Now, what do you think about when we're looking at outcomes in a 10-year horizon? There are a lot of other factors that now start playing a role in the event rate. For example, OMT, the intensity of medical therapy, things like that. Can you comment a little bit on that and how that was in DANAMI 3 PRIMULTI?
This is, of course, a very central point to a long-term follow-up. And especially with long-term data, we have seen that the effect of randomization is somehow diluted with time. So that is, of course, due to medications and other treatments that come along the road when you have a long-term follow-up. So, of course, that's something that limits what we can expect to see on the long term. And we unfortunately do not have any information on the treatments that occur during the whole long-term follow-up. And that could affect the outcomes that we see as it may be more pronounced throughout the follow-up period.
That's really interesting. Yeah, so I mean, at the end of the day, this is the only evidence we have in a 10-year follow-up. So, I find it really assuring that there's no late signals of harm, because the complete revasc arm ended up getting more PCI, so in terms of restenosis, other events, stent-related events, there seems to be a durable benefit of what was seen early. And that seems to be, for me, like one of the most important takeaways. And obviously, some of the questions about FFR versus angiography driven, still remain. And, obviously, there's another very large trial, as the complete 2 trial, which is ongoing. But I was just looking it up, and it's going to be a few years before that is repeated. So this is going to be our what we have at this time is going to be the totality of evidence for a while. And in my personal practice, I've not been using FFR a lot, except for sort of intermediate lesions, and that would sort of mirror the practice seen in complete, in which if it was 70% or more, you just go ahead and stent it, and if it is intermediate, you would do FFR, and it's easy to do that because it is very similar to how we use FFR in practice in general, anyways. So that is what I've been doing, but I'm still interested to know if an FFR guidance versus an angio guidance is a more superior approach, and I think we'll have answers more down the road.
Definitely.
Yeah.
And with this analysis, this study, of course, we cannot answer the question whether angio guidance is superior or non-inferior to FFR guidance. But what we can say is that it seems that a strategy of FFR guided complete revasc is safe, or seems is not associated with more events on the long term. On the other hand, it is associated with reduced future events on the long term.
Got it.
And we also see that it actually reduces repeated events. So it's reassuring to see.
Definitely. And, coming back to that point, in your study, you also have some landmark analyses at various time points during the study. And, that seems to illuminate a little bit about the timing of these revascularizations that happen in the culprit-only arm. So can you comment your observations on the landmark analysis and what you learned from it?
When doing long-term follow-ups, a lot of things can occur, as we touched upon with OMT and certain other treatments that may affect the outcome of the patients. That could also be dual antiplatelet therapy that stops after 1 year, and the effect of the randomization levels off during longer follow-up periods. And we therefore did a landmark analysis after 1 and 3 years. And what we see here is that the initial effect on the primary outcome, it's actually sustained over the years. So it seems that complete revascularization does not only prevent early events from occurring, but also later events, which is again mainly driven by revascularizations.
Yeah, I thought that was a really interesting result, and it seemed almost like between the 1 to 3 years there was still some divergence off the curves, and maybe after that things seem to stabilize. That's wonderful. Yeah, so those are kind of the questions I had, and thank you so much for answering them in in a really clear manner. And again, Dr. Marquard, thank you so much for joining us and telling us about your study. And we look forward to its presentation at EuroPCR. And again, excited to publish this in JACC, and it will be seen in print, an issue down the road. Thank you so much.
Thank you.